Well, good morning, all, and welcome to Medicine Grand Rounds. It occurred to me yesterday that because Grand Rounds is now offered across the system, I should probably just take a moment to say who I am. So I'm Mike Roy. I'm the chair of medicine at Maine Medical Center, chief of the adult medicine service line. And this morning, it's my really awesome, great pleasure to introduce our speaker, Dr. Rick Saad. Dr. Saad has joined Maine Medical Partners as our first adult gastroenterologist in the practice. So we're thrilled to have him, and thought this would be a nice way for him to get his name with a face out there, if you will. So just so you know a little bit about him, Dr. Saad went to University of Pennsylvania for his undergraduate degree, and then went to Jefferson Medical College for his medical degree. He did his residency training at the Brooke Army Medical Center at Fort Sam Houston in Texas. Following that, he did a period of military service and then completed his postgraduate fellowship in gastroenterology at the University of Michigan in Ann Arbor. He, along the way in 2011, received a Master of Science degree from the University of Michigan School of Public Health. He's been at Michigan since his fellowship, where he was a clinical associate professor of medicine. We're thrilled to have him join us both in general, but also today to give this talk in Medicine Grand Rounds. So Rick, thank you so much for being here.
Oh, thank you for the introduction, Mike. I'm also very excited to be joining the Maine Health family, and just a few additional comments, especially to the house staff and the medical students that have joined in for this presentation that I will be giving this morning. I have been in teaching hospitals since I graduated medical school in '95. So a big part of my career has been providing clinical instruction at all levels. And I'm very excited to continue that, those teaching activities here at Maine Health and at Maine Medical Center in particular. So with that, I'll begin my presentation this morning, which is entitled Management of the Hospitalized Patient with Inflammatory Bowel Disease. Just to give a couple of disclosures, I do perform consultative services with the American College of Physicians. I've been a part of the committee that puts together the GI and hepatology mix app that I'm sure many of you in internal medicine are familiar with. And I'm also a member of the question writing committee for the internal medicine and training examination, which I think a number of you are familiar with as well. The educational objectives of my presentation this morning are to review the identification and management of acute severe ulcerative colitis, review the management of fibrostenosing Crohn's, review the management of intra-abdominal abscess occurring in Crohn's, and speak a little bit about managing the IBD patient that is hospitalized or infected with COVID. To begin, ulcerative colitis is a chronic immune-mediated mucosal inflammation of the colon. As you see on this picture here, this would be an endoscopic appearance of fairly mild ulcerative colitis. Ulcerative colitis almost always involves the rectum. Only in a very small minority of adult patients is there sparing of the rectum. It can occur a little bit more frequently in the pediatric population. And ulcerative colitis can present at any age, although the peak incidence is in the second to third decades of life. It typically has a pattern of relapsing and remitting activity, and it also can present with a fulminant presentation, which can be quite severe, and we'll be discussing in great deal later in this talk. The classic symptoms of ulcerative colitis include bloody diarrhea, rectal urgency, and tenesmus, which is a constant sensation of needing to have a bowel movement. And here's another endoscopic picture. This is one of a much more severe case of ulcerative colitis. And ulcerative colitis is categorized based on its disease extent. Proctitis would be a case in which the inflammation is restricted to the rectum and maybe a bit into the rectosigmoid. Left-sided disease is a situation in which inflammation does not pass the splenic flexure. And then extensive disease is a presentation in which the inflammation involves the transverse colon and the right colon as well. Acute, severe, ulcer, acute, severe, acute, I'm saying I got a misprint there right on the top slide there. Acute severe ulcerative colitis is one of the dreaded presentations of ulcerative colitis. It's defined as 6 or more bowel movements a day and 1 or more of a variety of systemic signs of toxicity, which can include tachycardia, fever, anemia, or the presence of elevated inflammatory markers, either ESR or C-reactive protein. For children, the definition is based on the pediatric ulcerative colitis activity index exceeding 65. And acute severe ulcerative colitis, it can either occur as the initial presentation of de novo cases, or can occur in individuals with known and existing ulcerative colitis. And roughly a quarter of ulcerative colitis will require hospitalization for flares of their ulcerative colitis during their disease course. And of those hospitalized, nearly 40% may eventually require a colectomy during that presentation. So the tenets of management for acute severe ulcerative colitis is to hospitalize the patient and particularly to perform frequent, oftentimes more than once a day, both subjective and objective assessments of the disease severity, which again, I'll go into in a bit more detail on some later slides. It is also very important to prevent venous thromboembolism from occurring, which is very heightened in this category of patients. Also important to exclude infection, and in particular, C. difficile, cytomegalovirus, or the typical enteric pathogens that can cause acute diarrhea. It's also important to use intravenous corticosteroids, and it's important to get a multidisciplinary team involved in the care of this patient, including the gastroenterologist, a colorectal surgeon, infectious disease if there is an infectious complication. And I would add to this a dietitian. And then I'm going to go into the role of both imaging and endoscopy, as well as the roles of antibiotic and parenteral nutrition in the treatment of acute severe ulcerative colitis. One of the dreaded complications of acute severe ulcerative colitis is the development of toxic megacolon. And this is defined as colonic distension of 5.5 or greater centimeters on an abdominal film, and the presence of at least 3 of the following: a fever, tachycardia, a leukocytosis, anemia, the presence of dehydration, altered sensorium, the development of electrolyte disturbances, and/or hypotension. In this assessment, it's important that this assessment is done at the time of admission and regularly during hospitalization for acute severe ulcerative colitis, as this condition can develop at any point in time during the hospital course, and it can be quite rapid in its development. Another dreaded complication of inflammatory bowel disease is venous thromboembolism. It turns out that the risk of venous thromboembolism is 3-fold higher in the IBD population versus the general population. And this occurs both in the setting of ulcerative colitis as well as Crohn's. And there is actually evidence that maybe the Crohn's patients are even at greater risk than the ulcerative colitis patients. Disease activity seems to be a provocative element for the development of venous thromboembolism, and anywhere from 60 to 80% of those that develop an embolic event have active inflammatory bowel disease at the time that the embolic event occurred. Venous thromboembolism is also considerably higher in the hospitalized patient for their IBD flare versus somebody with a flare that does not require hospitalization. And that risk is actually comparable to individuals with cancer. So the risk of thromboembolism is very high in this hospitalized population. The other feature that's makes the identification of thromboembolism more difficult is oftentimes these individuals are asymptomatic. So it's important to pursue prophylaxis for venous thromboembolism in just about every situation. What you might decide on is whether to use anticoagulant versus mechanical prophylaxis. Now, the patients who should have the anticoagulant prophylaxis at the time of admission are those that are hospitalized with moderate to severe inflammatory bowel disease flare that don't have severe bleeding, those that are hospitalized with non-severe bleeding. Those that do have severe bleeding should still be prophylaxed, but with a mechanical device, and then switch them to an anticoagulant prophylaxis once the bleeding is no longer severe. In any IBD patient that is hospitalized for indications unrelated to their IBD, even if they're in clinical remission, should be prophylaxed as well. And finally, any IBD patient hospitalized for a major abdominal, pelvic, or general surgical procedure. So again, don't forget that all of these individuals need venous thromboembolism prophylaxis. And the prophylaxis used is you have options, and you can, it could be one of a personal choice or maybe one that's made with the patient. That could include low molecular weight heparin, low dose unfractionated heparin, and I'll go into those doses on some later slides, or the use of fondaparinux, which is a factor 10A inhibitor. There's also a strong association with C. difficile infection and having inflammatory bowel disease. And individuals with inflammatory bowel disease who also acquire C. difficile infection frequently require hospitalization. And a fair percentage of them can also go on to develop or to require a colectomy. The other thing about the C. difficile infection in this population is they may not have those conventional risk factors, including a recent hospitalization or the recent use of an antibiotic. So it's important to have a low threshold for both suspicion of and testing for C. difficile infection. And just a couple of years ago, the American College of Gastroenterology came out with their clinical guidelines on the management of ulcerative colitis, and specifically mentioned or specifically stated that all patients admitted with severe ulcerative colitis have stool testing done to rule out C. difficile infection. Regarding the C. difficile infection, vancomycin should be the first-line therapy, and pretty much across the board that has become the first-line therapy. Fidaxomicin could be used as an alternative. The corticosteroid therapy, it's important to understand that that should also still be continued, even though there's an infection with C. difficile identified and being treated. And this is because it's difficult to separate the effects of acute severe ulcerative colitis from that of the C. difficile infection. There can also be cases of fulminant C. difficile infection. This is typically defined as the requirement of an ICU admission, the presence of hypotension, the presence of an ileus or megalocolon, mental status changes, an elevated or low leukocyte count, or an elevated lactate level. And in the setting of fulminant C. difficile infection, there usually is the requirement for multiple forms of antibiotic therapy being used simultaneously, typically a formulation of oral vancomycin, as well as IV metronidazole, and maybe even the need for vancomycin in enema delivery for individuals that have severe distal disease. It's also important to get the surgeon and infectious disease on board for these cases of fulminant C. difficile infection. Moving on to another infection that oftentimes rears itself in an individual with inflammatory bowel disease is that of cytomegalovirus. Remember that this is a ubiquitous herpes virus. Infection typically occurs in young adulthood, either as a teenager or a young adult, and it's generally an asymptomatic infection. And then it remains latent in the body with a prevalence of greater than 70% in most adult populations that have been studied. The problem comes with CMV reactivation, which frequently can occur with immunosuppression. And this is estimated to affect up to a third of inflammatory bowel disease patients. CMV can either present as reactivation or as an acute primary infection. And it most often occurs either in acute severe or chronically active ulcerative colitis, particularly those with steroid-resistant ulcerative colitis, and may be present in as many as a third of individuals who are hospitalized with acute severe ulcerative colitis who are refractory to corticosteroids. It's also important to understand that it can also occur in Crohn's disease as well. So this can affect all forms of inflammatory bowel disease. So CMV colitis should be considered in all cases of acute severe ulcerative colitis, and there should be a heightened awareness in particular if there's the presence of fever, lymphadenopathy, splenomegaly, leukopenia, or the presence of mild hepatitis. Or there's been the prior use of immunosuppressants before the patient has been hospitalized. Even though you can test for the CMV in the stool or even serologically, the diagnosis requires objective evidence of CMV in colonic tissue. H&E staining is the most common way to, and certainly the cheapest way to identify the infection. And I've got a few slides here showing those multinucleated giant cells where the two arrows are pointing. And here's an up-close picture of those of that owl eye appearing cell that you may see on H&E staining. You can also have immunohistochemistry performed with antibodies to CMV, or if it's available, CMV DNA can be measured with real-time PCR. If the CMV infection is confirmed, its treatment consists of IC ganciclovir. Now, turning to the role of endoscopy in acute severe ulcerative colitis, the goals of evaluation should be threefold. Number one, to establish the severity of infection. And in particular, identifying deep ulceration is a pretty strong correlate with the likelihood of corticosteroid failure and the increased risk for the need for rescue therapy or for the pursuit of a colectomy. Its second objective is to confirm the diagnosis, especially in a case in which the individual doesn't have a pre-existing diagnosis of ulcerative colitis. And the final objective is to obtain mucosal biopsies to diagnose CMV colitis. Typically, a flexible sigmoidoscopy is sufficient. There isn't a need to pursue a full colonoscopy, particularly given the risk of dilation and potential perforation or microperforation that can occur with colonoscopy. And the ACG also came out with a statement in their guidelines on ulcerative colitis in 2019, stating that all patients with acute severe ulcerative colitis should undergo a flexible sigmoidoscopy within 72 hours and preferably within 24 hours of admission. So in terms of the treatment for acute severe ulcerative colitis, corticosteroids remain the mainstay of therapy. It's important to realize that there's no benefit beyond doses of 60 milligrams a day of methylprednisolone. And this can be administered as a single dose, as a divided dose, or even a continuous drip, but there does not appear to be any treatment advantage based on the method of administration. And topical therapy still plays a role if there are severe symptoms due to the severity of distal disease involving the rectum or the rectosigmoid. An alternative to the methylprednisolone can be hydrocortisone. It's usually dosed at 100 milligrams 3 or 4 times a day. And this response to the steroid should be seen within 3 to 5 days. And once again, therapy should be continued with either suspected or confirmed cases of C. difficile or CMV infection. When corticosteroids fail, cyclosporin or infliximab represent rescue agents. And it's very important that if one of these two agents is used in the setting of acute severe ulcerative colitis, that the surgeon has been involved and has directly spoken with the patient to give the pros and cons of proceeding to surgery versus an attempt at rescue therapy with one of these agents. So in terms of cyclosporin, to recall, this is an agent that's taken intracellularly into the T cell. It binds to calcineurin, and in binding to calcineurin, this prevents these nuclear factors from activating and leading to the synthesis of IL-2 and other cytokines. There are some contraindications to using cyclosporin. This includes the presence of hypertension, presence of renal disease, and specifically a creatinine above 1.4, a history of seizure disorder, A low total cholesterol, and in general, I would avoid its use in anyone with a total cholesterol less than 120. A low serum magnesium, particularly one that can't be corrected, a low albumin, or a prior failure to a biologic agent such as infliximab, because oftentimes you're going to use a biologic agent if once cyclosporin has been found to be effective. The other rescue drug, infliximab, also has a set of contraindications. And recall that infliximab is a monoclonal antibody to tumor necrosis factor alpha. Also realize that this is a chimeric antibody, which means it has a component of human as well as a component of mouse or murine material that is used to create this antibody. Contraindications would include presence of acute infection, the presence of latent tuberculosis, the presence of a demyelinating disease, and multiple sclerosis would be probably one of the more common conditions that would preclude the use of infliximab, the presence of heart failure, or the presence of a malignancy. So in terms of which agent to choose when you've reached a point to offer the patient a rescue therapy and the patient desires that rescue therapy over surgery, there are some factors that can be taken into account to help you decide which agent to use. So those factors that would favor the use of cyclosporin would be an individual who has not previously been using thiopurines, because thiopurines will also play a role if in cyclosporin responders. Those individuals who have not previously failed vedolizumab, that is a biologic agent that's a monoclonal antibody to the alpha 4 beta 7 integrin. The individual should have a measurable thiopurine methyltransferase activity. So the importance of TPMT is that this is an enzyme that plays a role in breaking down either 6-MP or azathioprine into its metabolites. And individuals with this low TPMT level have the risk of developing life-threatening myelosuppression. So again, the TPMT level should be elevated, and those with low TPMT levels probably should not be offered cyclosporin. Anyone with a previous anti-TNF alpha agent failure, anyone at risk for tuberculosis or hepatitis B, anyone with those contraindications to infliximab, or the insurance issues that may make infliximab not an option. So on the flip side, those factors that would favor the use of infliximab are those that have failed thiopurines, such as azathioprine or 6-MP, those that are intolerant to thiopurines, those that actually have a measurable, an intermediate or higher TPMT enzyme activity level, those individuals that have not tried an anti-TNF alpha agent, those individuals who are negative for latent tuberculosis as well as hepatitis B, those that have good coverage, and again, those that have contraindications to cyclosporin. If the cyclosporin rescue is chosen, it is very important that a surgical discussion is documented, that the patient has chosen to go with cyclosporin over potential colectomy. The dose should be given as a continuous infusion at 2 milligrams per kilogram starting dose. You want to use a dedicated IV line so that there isn't any disruption in the infusion with other agents being infused through the line. And it's always important to infuse in a volume of 100 cc's over 24 hours. That way the rate doesn't have to be adjusted. You should only make changes in the number of milligrams to prevent any confusion over rate changes. It's also important that you continue the IV steroids along with the cyclosporin. And when you're doing that, it's also important that pneumocystis pneumonia prophylaxis is initiated with Bactrim 3 times weekly. If cyclosporin is used, monitoring every 15 minutes during the first hour infusion for any allergic or anaphylactic symptoms is also very important. And in terms of the protocol, there are labs that need to be drawn before initiating the cyclosporin to assess kidney function, cholesterol level, magnesium level, and a pregnancy test if it hasn't already been done. During the administration of cyclosporin, it's important to review for any adverse effects on a daily basis. I've listed here the more common and severe adverse effects, including dyspepsia, dizziness, nausea and vomiting, headache, flushing, muscle weakness or spasm, clumsiness, or the development of seizures. It's then also important to follow blood pressure quite frequently while the waking hours each day. And cyclosporin levels need to be followed starting on the second day and done daily until there's a stable cyclosporin dose appreciated. And there is a cyclosporin dosing table that I've provided on this slide as well. In addition to that, labs should be done at least every other day, including checking creatinine, potassium level, serum magnesium level, cholesterol, liver function studies, inflammatory markers. And it's also important to follow stool number and for the presence of blood in the stool on a daily basis to track response to the cyclosporin. With regard to a cyclosporin response, if there is a response within 3 to 7 days, the patient would be switched to oral prednisone. You would discontinue the IV cyclosporin, and the following morning, approximately 12 hours later, you check a level before giving the oral dosing of cyclosporin, which is roughly 2 times the IV dose to the nearest 25 milligrams. And it's important to note that it's dosed twice daily. Patient should be observed for 1 to 2 days on the prednisone and oral cyclosporin, and then can be discharged on a prednisone taper, initiating the thiopurine, continuing the PC prophylaxis. And you definitely want to have close follow-up arranged with a gastroenterologist following that discharge. Here's a diagram that outlines how to approach infliximab if it's used as a rescue agent. The initial dose would be 10 milligrams per kilogram. You then want to check the C-reactive protein anywhere between 60 and 66 hours after that initial infusion has been delivered. If there is a reduction in the C-reactive protein to less than 0.7, you can basically follow the outpatient process of loading and administering infliximab, which is the second dose in 2 weeks, a third dose at 6 weeks, and then every 8 weeks thereafter. If there is less than a 20% drop from the pre-infliximab level, you should discuss having this patient go to surgery. If there's been a reduction by at least 20% from the pre-infliximab level, you can discuss with the patient either going to surgery or administering a second dose of infliximab 72 hours after that initial dose was administered, and then rechecking the C-reactive protein level again 60 to 66 hours after that second dose administration. If the C-reactive protein remains greater than 0.5 and the patient is symptomatic, they should then go to surgery. If the C-reactive protein does drop after the second dose to less than or equal to 0.5, then you administer the outpatient dosing program that I mentioned already. So in terms of acute severe ulcerative colitis and surgical evaluation, this should be an early assessment. Have your surgical colleagues involved and have them know about the patient as early as possible, because there are absolute indications for urgent surgery, which would include development of a perforation, uncontrolled hemorrhage, or the development at some point in time of toxic megacolon. Other indications would be that failure to respond to IV steroids within a 3 to 5 day time frame. In terms of deciding who to counsel on the pursuit of colectomy, there are a number of general predictors for an individual likely to undergo or need a colectomy. That would be a fever, tachycardia, persistently high C-reactive protein level, severe endoscopic findings, and in particular those deep ulcerations, the presence of hypoalbuminemia, the development or persistence of colonic dilation, non-response to prior steroids, or the presence of a C. diff infection. There are a number of risk indice tools that you can use on day 3, that is after 72 hours of IV steroids, to provide the patient with some pretty specific predictors in terms of their need for surgery. These 3 indices include the Travis index, which is based on the presence of the number of bowel movements a day, or a combination of bowel movements and C-reactive protein. The Ho index, which is a point-based system, or the Lindgren score, which is a value that you get from adding the stool frequency per day to the C-reactive protein and getting that score. And as you can see, these indices predict a very high positive predictive value for needing surgery in the mid-80s for 2 of the indices. It's also important to recall that or understand that the use of infliximab or cyclosporin as a rescue therapy for a brief period of time does not increase postoperative complications, and the use of one of those rescue agents should not be a reason to delay the pursuit of a colectomy. Other management considerations for the individual who's hospitalized for acute severe ulcerative colitis is that of pain management. You definitely want to avoid narcotic analgesics because they can precipitate the colonic dilation and even the development of megacolon. Also, make an effort to avoid NSAIDs. These have been associated with a fair number of IBD flares and could certainly make the hospitalization worse for the patient. Alternatives for pain management would be the use of heating pads, acetaminophen, anxiolytics, and sedatives. Empiric antibiotics should also not be routinely used unless you're dealing with a case of fulminant colitis or there may be the presence of peritoneal signs on exam. Also avoid TPN for the purpose of bowel rest. There's been no proven benefit of periods of TPN over placebo. There's also considerable risk for catheter infection and the development of an upper extremity DVT. And the mantra is to advance the diet for the patient once the patient is hungry and tolerating oral feeding. So my next 5 slides give, this is probably good for the house officers, and you can see my reference down below, but on each day there's a checklist that you may want to have on your checkboard to approach the care of a patient with acute severe ulcerative colitis. So there are a number of studies you'd want to order at the day of admission. Particular studies to mention would be getting total cholesterol as well as an iron saturation in addition to the typical labs. Getting that TPMT enzyme level early on so that you know whether this patient is even a candidate for azathioprine down the road or even cyclosporin down the road. Gold quantiferin is the best way to assess for latent tuberculosis, especially somebody who's already immunosuppressed. I would imagine that can be done at Maine Health. An abdominal film is also a key study to assess for the presence of colonic dilation and also to assess for any presence of free air. Stool cultures are important, particularly that GI PCR panel to look for other infectious etiologies. Again, you can do a CMV PCR, but you're going to need to find CMV on the biopsies to truly address a C. diff or a CMV infection. Schedule that flex sig that should be done at the latest the next day. And this is where you begin recording the number of stools, how many of those stools are bloody, the presence of urgency or tenesmus, as well as any signs of toxicity to suggest the development of toxic megacolon. Get GI involved early on that first day. Consult surgery, particularly if this individual has been on outpatient steroids or they've been on IV steroids for several days and they're a transfer from another institution. There is no need for routine CT or MRI at the onset at admission. And in terms of what you should, at a minimum, what you should be writing for is either Lovenox or sub-Q heparin for VTE prophylaxis. IV fluid is important to produce a urine output of at least 50 cc's an hour. Keep the patient NPO, at least on day 1. Get them a bedside commode because they're going to be using the bathroom oftentimes quite frequently. Start IV steroids if there's no signs of overt infection. Solumedrol can either be given every 6 hours or as a single dose at 60 milligrams. And if urgency is a major component, you can consider a topical mesalamine product such as Canasa, which is delivered as a rectal suppository. On day 2, get that flexible sigmoidoscopy, continue to record stools and how many are bloody, the presence of urgency. Again, you want to call surgery if you haven't already, especially if signs of toxic megacolon develop. In terms of treatment, continue your VTE prophylaxis. You titrate IV fluid to a urine output of 800 cc's a day. You can now start to feed them, particularly if they're hungry. I'd start with liquids first. Continue the IV steroids. And again, if rectal urgency is a major component, you can consider those mesalamine suppositories. Day 3 is a big day. This is a critical time point in deciding whether the steroids are working and whether it's time to either talk with the patient about colectomy or talk with them about rescue therapy. This is when you want to review your quantiferon results, review the biopsy results from the sigmoidoscopy, make sure there isn't CMV, probably obtain another abdominal film to assess bowel diameter. And this is the point where you may consider a CT enterography to assess for any small bowel disease. Maybe this isn't Crohn's disease after all. Maybe it's Crohn's or ulcerative colitis after all. Maybe it's Crohn's disease, or maybe there's small bowel disease of some type going on. You also want to follow up on your C. diff results at this point. You want to calculate those risk indices and document them in the note. And again, if surgery isn't involved or they are involved, you may want to call them back if the individual is not getting better and those risk indices, any one of them are positive. In terms of the treatment side, continue with your VTE prophylaxis, continue IV steroids. If the INR is elevated at this point, you may want to consider vitamin K, particularly if they're heading towards surgery. You can improve, you can continue to increase their diet if they're doing better. And again, you can address rectal urgency symptoms with either suppository or Roaso, which is the enema formulation of mesalamine. And this is also the stage where you may consider that rescue therapy. Day 4, if there's no rescue therapy that's pursued, continue to follow your stool output, continue to follow with films, continue labs, and you want to continue with your VTE prophylaxis. Continue to titrate IV fluid to keep urine output 800 cc's a day or more. You can consider the soft diet at this point if they're hungry. You can continue the IV steroids, again, address rectal urgency. And again, if they're not improving at this point, continue to bring up the discussion of either rescue therapy or surgical intervention. And then finally on day 5, continue to follow labs, a film if necessary. You can recalculate those predictive scores. If they weren't severe at day 3, they may have changed by day 5. You still may want to call surgery back if those C-reactive protein levels are still elevated or they're still having more than 5 bowel movements a day. From the treatment end, continue with your VTE prophylaxis, continue your IV fluids, continue the IV steroids, again, address rectal urgency. If they're doing well and tolerating the diet at this point, you can start to begin preparations for discharge. If they're failing steroids at this point, surgery is really going to be their only life-saving option. So now moving on to Crohn's disease. This is a chronic immune-mediated transmural inflammation. This can involve any part of the GI tract. The most common presentation is the individual with ileocolonic disease. About 30% have ileo disease alone, and about 20% have colonic disease alone. And upper GI tract involvement is in a minority of patients, somewhere in the range of 5 to 10%. The other thing about Crohn's disease is it can be segmental. So you can have areas that are completely normal in between diseased areas, which we call skip margins. It's typically chronic, progressive, and a destructive disease. And roughly half of those individuals with Crohn's disease will develop intestinal complications such as a stricture, an abscess, a fistula, or a phlegmon within 20 years of their diagnosis. The symptoms of Crohn's disease are far more numerous than ulcerative colitis, and those most common symptoms include abdominal pain, diarrhea, fatigue, loss of appetite, weight loss, growth failure, anemia, or the development of recurrent fistulas. It's also important to understand that there are no pathognomonic features. So Crohn's disease usually is a diagnosis that involves combining endoscopic, radiographic, and histologic criteria with evidence of chronic intestinal inflammation being present on usually more than one modality of testing. In this picture here, this is actually a video capsule picture that shows one of those deep ulcerations that may be seen in the small bowel with someone who has Crohn's disease. And the phenotype of Crohn's disease can vary in the individual. Some people will just have the inflammatory component. Others will develop fibrostenotic complications, which is usually the development of strictures. And others may develop fistula or penetrating disease. And then there are individuals who develop both fibrostenotic and fistulizing disease. Individuals with Crohn's disease are typically hospitalized because of one of three reasons: either an exacerbation of their inflammatory bowel disease, a non-inflammatory disease-related complication, such as an abscess, a phlegmon, or a stricture, or a medical complication that may be related to their Crohn's disease, such as a thromboembolic event, a secondary infection from their use of immunosuppressives, for instance. And there are a variety of hepatobiliary as well as pulmonic complications that can come with Crohn's disease. In terms of the tenets of management for that hospitalized Crohn's patient, once again, venous thromboembolism is important. Also, the exclusion of infection, and just as I discussed with ulcerative colitis, that typically includes C. difficile infection, cytomegalovirus, and then again, the typical enteric pathogens. Imaging is more important in Crohn's disease, and in particularly that of axial imaging with either a CT or an MR enterography. And it's important to get that enterography and not just a routine CT or MR, which I'll talk about in a little bit further in some later slides. And then managing the inflammation with typically a combination of corticosteroids as well as biologic agents. Nutritional issues tend to be a bit more important in the Crohn's patients because of the effect their disease has more systemically, and also involving the small bowel where absorption occurs. So it's important to address hydration, electrolyte replacement, and frank malnutrition issues. And again, the multidisciplinary team approach is important at the onset and during the hospitalization, including GI, surgery, and also the radiologist in the case of Crohn's disease. And it's also more important to involve the dietitian in Crohn's disease as well. Axial imaging, once again, should either be a CT or an MR enterography. Both are highly sensitive and are fairly equivalent in terms of evaluating the disease activity of Crohn's disease. And in particular, they can identify the anatomy of any bowel narrowing. There are some limitations in their accuracy in identifying bowel narrowing can be diminished due to inadequate luminal distension. And neither study is very good at distinguishing the fibrosis from acute inflammation at a stenotic site. The presence of severe or fulminant Crohn's should be treated with intravenous corticosteroids or one of the anti-TNF alpha agents, such as infliximab, adalimumab, or certolizumab. And infliximab in particular should be considered in fulminant Crohn's disease. Again, the dose of methylprednisone should be somewhere between 40 and 60 milligrams a day. And you also may want to consider bolusing the corticosteroids before administering one of the biologics, such as infliximab, to prevent, and in particular infliximab, to prevent the anti-drug antibody development. Again, recall that it's a component of the antibody is from a mouse. If the individual is admitted for fibrostenotic Crohn's disease, their presentation can be variable. They can present with either partial or complete bowel obstruction. There's oftentimes pain that's present, and there may be a complete inability to eat. As this picture demonstrates here, this is a stricture that's developed in the small bowel. The evaluation should include both subjective as well as objective components. In particular, you want to understand the history of their disease course, whether they've had prior episodes of obstruction or surgery, whether there's weight loss present, their ability to tolerate a regular diet. And axial imaging, as well as a comprehensive metabolic panel, are important for the assessment of the stenosis, as well as to assess for anemia, malnutrition, or electrolyte disturbances or dehydration. So prompt decompression for either bowel obstruction or recurrent emesis is important, using a nasogastric tube to low intermittent suction. Again, following lab work, and in particular the electrolytes, as well as to assess intravascular dehydration. The timely initiation of parenteral nutrition, because both weight loss and malnutrition can be very severe in the Crohn's patient with fibrostenosis. You want to be very judicious with any narcotics for pain. They can particularly worsen the symptoms of nausea, vomiting, or bloating. And again, can't remind you enough, the VTE prophylaxis is an absolute must, and the use of IV corticosteroids if inflammation is present on imaging. So here's a typical or a recommended algorithm for the addressing bowel obstruction in Crohn's. Again, you do your initial management with decompression, IV hydration, electrolyte replacement. You get your labs and your imaging. If there is objective evidence of inflammation, you want to treat with corticosteroids or optimize their other therapeutic drugs that they're using. If there's been a failure to respond in the medical therapy after 2 to 3 days time, they will likely need either surgery or endoscopic balloon dilation. And the features of that stenosis, which are outlined in that big box in the middle, will help dictate whether to go to surgery or to have endoscopic balloon dilation. Typically multiple strictures, a large stricture, angulation, any pre-stenotic dilatation, and any colonic obstruction should go to surgery because of the potential presence of underlying malignancy. The other complication associated with Crohn's disease can be the development of intra-abdominal abscess. It's important to understand the distinction between abscesses and phlegmon. Abscess is walled in, whereas the phlegmon is unbounded, and the phlegmon can actually spread along connective tissue and muscle fiber, as opposed to the abscess, which stays confined to its walled in area of infection. The treatment in this situation is twofold, with the simultaneous treatment of the infection as well as the underlying Crohn's. And again, a multidisciplinary approach is important, in this case involving infectious disease as well as the radiologist along with the surgeon and GI. The tenets of treatment is to image the abscess with either a CT or MR enterography. Antibiotics that are used should be directed towards an enteric pathogen because the infection is typically going to be polymicrobial, and I've listed the most common infectious agents involved. And those failing antibiotics or developing a recurrent abscess will require drainage. Typically, percutaneous should be pursued before that of surgical. Percutaneous has a lower likelihood of success, but it's less invasive, has less complications, and it might actually make a surgical approach less likely to be complicated if it's tried first. And immunosuppressive therapy to the control of the Crohn should be initiated after achieving control of the infection. And this is oftentimes going to take a multidisciplinary decision approach. Here's a list of proposed initial antibiotic therapy for intra-abdominal abscesses. There are a variety of single agents, most of which are third-generation cephalosporins, broad-spectrum penicillins, or quinolones. It is important that the specific antimicrobial should be chosen based on local antibiotic resistance profiles and/or discussion with the infectious disease specialist. With regard to intra-abdominal abscess and the pursuit of surgery, the primary goal is to minimize any surgical complications in the need for a stoma. And the way to minimize those complications would be the pre-surgical use of antibiotics, an attempt at percutaneous drainage, bowel rest, and the use of enteral or TPN if necessary to get the patient's nutritional status improved. That period of bowel rest isn't defined, but it shouldn't exceed more than 2 or 3 weeks. And then weaning those corticosteroids if possible preoperatively. And here's a management algorithm for addressing an abscess. So the first decision-making is based on the size of the abscess and whether it's recurrent or occurred in the presence of steroid use. If the answer is no to all of those, you proceed with antibiotics and then follow for a clinical response. And that may either lead to repeat imaging immediately or later on, depending on the initial response. If the abscess is large, recurrent, or occurs in the setting of steroid use, pursue percutaneous drainage with cultures to direct your antibiotics, and then the use of directed antibiotics. If that drainage is not successful, then you want to initiate TPN or enteral feeding, continue the antibiotics, and have this addressed with the surgeon for likely surgical drainage. And just a couple slides on IBD and COVID-19. This has been, I will say that over the last 18 months, there has been a lot published on this, and it's a moving target. Things have changed repeatedly on managing the IBD patient in the setting of COVID. What I've got here is probably the latest information I could find. And what this is telling, and these are usually just population-based studies, and what I'm finding here is that there is an increased risk of more severe COVID in the IBD patient who's elderly, has comorbidities, is on systemic steroids. So steroids seem to be the biggest immunosuppressive agent associated with bad COVID infection outcomes. And combination therapy with both a steroid and a thiopurine also appear to be worse, certainly worse than the TNF alpha and other biologic agents. There's even been some recent data suggesting that mesalamine therapy may increase the risk of more severe COVID-19 and IBD. The biologics, fortunately, seem to not increase any risk at this point. So a decision tree that you may want to use here is, this is an individual who's on IBD therapy, who has stable disease. This may not be somebody who's hospitalized, it could be. But if they have no known or suspected COVID-19, basically continue their IBD therapy, continue their biologic infusions at the appropriate time frame, but only perform an endoscopic procedure if it's urgent or emergent. If they have positive testing for COVID but don't have symptoms, you would most likely want to hold the thiopurines as well as the methotrexate and tofacitinib. And you may want to delay the biologic therapy for 2 weeks while monitoring for COVID symptoms. If the individual has tested positive for COVID and has symptoms, you basically want to hold everything and then restart after symptom resolution or follow-up testing reveals that they've resolved their infection or have developed convalescence. So in terms of the IBD patient who has COVID and GI symptoms, the approach should be to exclude known enteric infections, and in particular that of C. diff. Confirm active inflammation with non-endoscopic means, if possible, with either a C-reactive protein, a fecal calprotectin, or even cross-sectional imaging. And the IBD treatment should be based on the presence of inflammation and disease severity. Procedures, endoscopic procedures, should be reserved for urgent and emergent. And specifically, these would be procedures that would change management. For instance, is there a need for biopsies to either diagnose new severe IBD? Is there a need for biopsies to exclude cytomegalovirus if the non-invasive tests are not do not confirm the diagnosis? Or whether there is severe disease or suspected cancer where mucosal inspection is necessary. And finally, don't forget VTE prophylaxis for these individuals. So my key points for the hospitalized IBD patient is early involvement of GI, especially patients with known IBD or those who are presenting with a suspected initial presentation of severe disease. Early involvement of the surgeon, especially if toxic megacolon is suspected, there's a suspicion of obstruction, or there's a presence of an interabdominal abscess. Cannot stress VTE prophylaxis enough. That should be started immediately at admission and continued during the entire hospitalization. It's important to exclude enteric infections, especially C. diff and CMV. IBD therapy should generally be continued unless there's a life-threatening illness. And don't forget the timely assessment of the nutritional status of the patient. So at this point, I can take questions. I'll take a look at the chat box, and if anybody wants to just unmute themselves and ask a question, feel free. I'm not seeing anything in the chat box, so does anybody have either a question they want to put into the chat box and I'll read? Let's see, I do have one question here. Would you add psychiatry, social work when indicated, ostomy nurse to your multidisciplinary team? Certainly, and I think it depends on how your patient is presenting themselves during the hospitalization. One thing I didn't talk a lot about, and I thank Dr. Roy for bringing this up, the presence of depression and anxiety is immense in this population, especially these people that are living chronically with their illness. And psychiatric illness seems to worsen their disease in many ways, and in particular with quality of life measurements. So it's important to involve psychiatry if it looks like they would benefit from that assistance. And as far as a social worker is concerned, absolutely these individuals require all kinds of therapy and assistance with getting to their frequent visits or their infusions. So it's important to involve the social worker and make sure there isn't a family situation or a personal financial situation that's impairing their ability to get good care. Because the best way to treat these IBD patients long-term is to keep them out of the hospital, keep them from developing their flares and their complications. And certainly if they have surgery on an ostomy, or they have an ostomy already present, getting an ostomy nurse involved is also a good suggestion. So thank you for that comment. Anybody else that wants to unmute? Or
I have a question. First off, thank you so much. This was an outstanding review, and I really like the checklist as a one of the residents. My question is, how does your management change for patients who have megalocolon but are not toxic? So say you get a KUB and they have evidence of a dilated colon, but they're not necessarily toxic at that point. Does that change anything for you?
Well, if they're not toxic, I would still, I mean, number one, I'd get a surgeon involved. And I think it's not, and not just get the surgeon involved, but make sure the surgeon probably sits down with the patient too. But if they're not toxic, you could, at this point, follow them very carefully with serial exams, initiate the IV steroids, and get imaging frequently if you need to. You know, the thing is that these patients may have developed some form of ileus, or they may be dilated because they're on narcotics, or the dilation may just be a part of their flare. As long as they're not toxic, you probably have a little bit of room to work with. But if they're developing any of those signs of toxicity that I outlined for you, or their abdominal exam is getting worse, or they're getting more dilated, I would not waste time at all. And like I said, I would have, if there's a dilated colon on presentation, I'd get surgery involved, make sure they are familiar with the patient, they know the patient's history, the patient has had a chance to meet the surgeon, so that you can move fast if this develops into a toxic megacolon presentation. Because it can evolve very quickly. I've seen this happen.
Rick, there's another question in the chat from Dr. Erickson.
Yeah, is there a subset of patients who present with acute colitis that ultimately prove to have non-specific or self-limited colitis, and they can be identified from the new onset ulcerative colitis, and is management different in the setting? So there are, you know, I would say I probably get consulted the most for somebody who comes in with an acute diarrhea and a CT. I mean, a CT gets done in the emergency department almost universally. I would imagine it's probably similar here at Maine Health. And what's seen on that CT is this diffuse bowel wall thickening, you know, colitis. So there are, and the overwhelming majority of those, I'd say 90+% of those end up being some infectious etiology, frequently one we don't even identify. So generally what happens in those patients is they're treated with supportive measures. We strive to do a colonoscopy in those individuals before they're discharged, if it's possible. COVID's kind of making that a little more challenging, but it is important to exclude an infection. That's where that GI PCR panel is very valuable. And the most important thing you're going to do is an endoscopic exam and get biopsies, because you have to find chronicity on the biopsies, any evidence of chronicity, granulomas, for instance, to differentiate an acute form of colitis from a chronic form of either ulcerative colitis or Crohn's disease. Typically, somebody with acute severe ulcerative colitis that presents, they're not just going to have that garden variety infectious colitis. They're really sick. I mean, we're talking about bloody diarrhea. And that's the other thing, is many of these acute colitis are not bloody diarrhea. They're non-bloody diarrhea. So there is a large subset of patients that come in with acute diarrhea and have bowel wall thickening on CT imaging, and they will prove to not have ulcerative colitis the overwhelming majority of the time. But it's going to oftentimes require a colonoscopy, typically in the hospital, but if not, maybe a few weeks out. If they're doing, you know, if they're clinically doing very well, it would be a few weeks or even a few months out. I always follow up with a colonoscopy in those people, because ischemic colitis is another form of colitis that could be missed or not appreciated.
Well, it looks like we're just a tiny bit over our time. Rick, I want to thank you so much. I agree with Dr. Michaud. This was an outstanding and very helpful practical review as patients, as we deal with patients coming into the hospital with these serious problems, really. So thank you very much for presenting this talk.
You're welcome. And by the way, do they have access to the slides going forward, or how does?
Heidi can make them available, and actually the talk is recorded and will be available on our designated YouTube channel. So
I just wanted to point out on some of those references I used, there's a it's a 15-page long document that was used at my prior institution by the IBD group there. We were blessed to have an IBD group, and they put together a very detailed approach to treating acute severe ulcerative colitis. And that's where that checklist, I kind of modified it a little bit, but that's where that checklist comes from. It'd be an invaluable thing for a new house officer to carry around with them. Because these patients, they can really be scary when they come in. These ASUC patients can be very, very scary, and they can go downhill in hours. I mean, you can leave them in the night and think everything's fine and come in the next morning and find out they went to the OR in the middle of the night. Do not take these individuals lightly. They will change on you at the drop of a hat.
absolutely. Well, thanks again. Very well done. Appreciate it.
And I look forward to working with everyone.